All right, so hi everyone. So I'm Yona, I'm from Toronto in Canada, and I'm going to talk a bit about our ECHO program. Every ECHO is a bit different, but I'm going to try to give, I'm just curious actually, has anyone participated in any kind of ECHO before?
Yes, I have. Around a substance abuse program, we had an ECHO.
Okay.
So we just finished one for adults, healthcare for people with autism.
Oh, okay, great. Yeah. So the Autism ECHO has been around for some time, and they do really interesting things. That's kind of branched out into a number of different areas. And they are just starting to do some more sort of autism ECHO related stuff with adults. Our sort of home of ECHO comes from one that's focused on mental health. So not about developmental disabilities or autism, but mental health. And so we've been sort of building off of that framework. But every ECHO, I think, has certain things that are the same and then certain things that are different. So I'll kind of just give a quick kind of, here's what we've been doing, here's what we've learned, and then we can hopefully just have a nice informal discussion. Okay, so this is kind of a visual of what Project ECHO is really about. And it meant something different and it worked differently pre-pandemic. So the idea here is we have experts in a particular area, and originally in New Mexico, these were experts around things like opioid use and prescribing, but those experts aren't everywhere. So we build a community of practice, which is that kind of middle area of people who participate by meeting regularly with these subject matter experts in their own communities. And then they can spread that knowledge kind of below them to all these other people reach. So if you can imagine, like right now, I could be the expert, and then you as the group are my community of practice that I work with, and then you take all the knowledge we've shared and you bring it to your people. So there's a few sort of key principles to all the ECHOs, and you have to kind of follow these rules or you're not an ECHO. So first of all, we're using technology. And now, of course, everyone uses technology, but when ECHO started, really no one did. There's a lot of sharing of best practices that are based in evidence. So it's not just, I really love doing this, you should all try it. Look at what I tried. There is sometimes that innovation, but we're always trying to draw it back to what we have evidence for. We also use case-based learning a lot. So I think everyone has done a million webinars and they have their place, but when you actually bring a case to a community, talk it through, get suggestions, that helps you in a way and you learn in a way I think that's different than when it's just sort of more lecture-based kind of material. And also there's this sort of ongoing monitoring and improvement that's sort of done across the ECHOs to sort of figure out what's working, what's not working. The sort of motto of ECHO is all teach, all learn. So a really important part of the ECHO is you see at the top of this diagram, the subject matter experts, but we kind of recognize, and I'm reminded of this I've been doing ECHOs almost every Friday for about 2.5 years now, that really we're all experts, right? We all have something to learn and every voice matters. And I think, you know, that's why something like this, I think, could be so fitting for any kind of group where some people are marginalized or feel like their voice is less important. So whether it is kind of the patient voice or the family voice, or people who work in social services who are paid in direct care jobs versus doctors, or nurses versus doctors, like this idea of all teach, all learn really tries, I think, in some ways to get rid of some of that hierarchy and to recognize that we all have something to offer. So this is just a visual of how the ECHOs in Ontario kind of developed. So there's a lot of acronyms here, but ONMH stands for Ontario Mental Health. So initially there was just one ECHO that was done, training with New Mexico, started in September 2015. And then just gradually every year, another version of the ECHO would be started out of our hub in Toronto and Ontario. So we have one on addiction medicine, we have one on OCD, we have one on trans and gender diverse health. There's a really important Indigenous peoples ECHO that runs out of Ontario. And then in January 2020, like having no idea a pandemic was coming, we launched a 12-week ECHO that's focused on adults who have intellectual or developmental disabilities and sort of looking at sort of how to teach cross-sector stuff on mental health issues. So this is just a visual of how many people have been reached and how many organizations have been engaged in our province, which is Ontario. So Ontario is like a big state in the US. Some of the work I'll talk about now, we actually have been doing nationwide, Canada-wide, but we're funded to sort of run this program just for our province or our state. I say province because we don't have states. Okay, so this is how it used to look when we ran the ECHO, and it was really lovely. We'd sit all of us in the hub in this room together. Someone would always bring in a treat. We would have coffee. We would give each other like signals. Are you going to go? Are you going to go? Because we sort of to know who's going to speak. So it was very engaging. And all the people who were sort of leading the echo, who were the quote experts, were sitting in this lovely space together. And you can kind of see in the picture the screen of maybe the presentation that we're giving, and then another screen that has all of the faces of the people using Zoom who are on the spokes, right? The other people participating. And of course, that all changed during COVID. So we have our Echo hub that are really looking exactly like our Echo spokes because we were all on Zoom, which was an important transition. It has changed how we work because we're two-dimensional now, and we have to think of ways to communicate with each other as a teaching group, even though none of us are in the same space. That helps us make things run as smoothly as possible to everyone who's part of the spokes. Okay, so I'm going to spend a bit of time giving you an overview of the course that we've developed. We had this 12-week course before COVID, and then we rapidly transitioned it into a 6-week program during COVID, which we've actually been running now for over 2 years. So a few things I'll highlight if you're reading the slide. So first of all, the focus of our work has been on mental health challenges during the pandemic. So we have specific topics or sessions where we cover certain things. Who is in the echo is really important. So you see this nice picture of different people's faces. We have a psychiatrist on our team, a psychologist, a family physician, social worker, occupational therapist, patient perspective, and family perspective. And then the spokes are everybody from around either the province or our country. And importantly, we have all the different healthcare disciplines are invited, but we also extended our echo so that it's also for people who work in social services. They might be case managers, they might be, running a group home, they might be giving direct one-to-one care to an individual, and they have a college degree or they have no diploma or anything whatsoever. And we've kind of embraced this all teach, all learn philosophy because we all need to learn how to work together. And it's really, if I'm going to make a point about what we've learned, it's really important to figure out how, when we evaluate how our echo has gone, when we hold it in this manner, I was kind of worried, first of all, would the physicians kind of find it too, not advanced enough for them, because sometimes the cases are presented by someone with very little clinical experience. They're going through, we have a set template that helps people sort of do their case presentation. But the gaps in knowledge in someone who hasn't had any medical training compared to maybe if a physician is presenting a case, it's going to be very different, right? So we were kind of worried about how that would go for physicians, as an example, or any healthcare provider. And what our feedback has been is, it's actually really helpful for us to be able to hear, from their perspective, how they see things and what happens. Because I didn't realize that's how those people work, or that's what they're thinking about. Yeah. Right. So everyone's kind of learning through the process of learning together, actually how they really could work together. And I think that's a very important part of building this community and kind of modeling different ways to interact. So even though we have different levels of expertise within our group and different languages that we use, it's an opportunity to sort of learn other people's languages and to learn to respect different people. And I see, Janet, that your hand is up. Do you want to ask a question now?
Is that okay?
Yeah, I don't care. Is it okay with everyone else? It's fine with me.
Let me just say I'm completely jealous of the numbers of folks that you've been able to engage in doing this. My question was, do you provide incentives? Is this just out of the goodness of people's hearts that
so the number that I showed in that earlier slide was of all the echoes through the Ontario Mental Health Program.
Yeah,
so our program has had about I think 900 people have gone through. And no, we don't give incentives. Why do they do it? It's an interesting question, right? I think if it wasn't COVID, would our numbers be the same? I'm not 100% sure. I think the length. So one thing we did, and I'll show some data in a second, but we had our 12-week echo, and then we changed it to the 6-week COVID echo. And no one had really done a 6-week echo before. Everyone was doing either 12 weeks or 18 weeks, and attendance was pretty good. People would come much of the time, not all the time. But we thought we really need to give people basic information right now to respond. And this was in March. We started our COVID echo the very beginning of April. We were just finishing actually the in-person echo, and we switched it to online Zoom for our last session of the 12-week echo was how to deal with COVID. And it was in the middle of March when everything shut down. So we switched it to 6 weeks. And what was really interesting when I show you our numbers is that our data in terms of people's satisfaction, people's self-efficacy, what they learned from the course was actually pretty similar to what you would have seen in the much longer courses. And it makes you ask, and the attendance was better. So it makes you ask, is it better for us to have longer programs where people sometimes come, sometimes don't, but they get to learn a lot? Like there's a lot of topics we don't cover. So you can see the list here on the screen. We talk about grief and loss, depression, anxiety. There's no session on suicide risk, right? There's no session that's just on psychotropic medications. There's no session on aging with a developmental disability and mental health issues. Those were topics we could cover when we had 12 sessions, right? But we've had to condense things. So you don't get the same depth. But the question is, how do you engage people? Do they do better when they have, you know, more sessions, more time to get to know each other, more cases, or are they more likely to show up if they have less information for a shorter time? So we were having, for some of our echoes, we would have 100 people register for the echo. And there was no incentive or anything for it, right? And people came, like they stayed. Now, right now we're holding an echo. If anyone wants to observe one, like right now, we're doing them on Fridays and we have 3 sessions left. Our registration is lower. It's actually the lowest it's been out of any of the echoes. I wouldn't suggest doing it in the summer. And I think right now, people are so tired of COVID and just so tired of anything that they just don't want to do it. So I think you have to kind of, you know, take the pulse of your community to know who's going to participate. I think opening it up so it's not just healthcare providers there's very little learning for people in what we call social services in Canada, right? Like there's no training available to them. And so for them to be able to learn from a medical, largely, you know, medical team, but also with people who are participating who are in the health sector really helps bridge. Like one of the biggest challenges is that these 2 sectors don't understand the same things and don't work together. So the fact that we hold it together gets a lot of them to register as well as folks in health. So Diane, your hand is up as well. And then maybe I'll just try to finish the slides. I don't have that many. Go ahead.
Oh, I'm just wondering, so there's no continuing education credits
Oh,
involved?
that's a good point. Yes, I didn't even think of that. So it's funny, in Canada, we do give for physicians, we give credits, but we actually don't have processes. Like if I'm a member of the APA, I can count that I took this course, but we're not getting APA accreditation. And in CPA, which is our Canadian Psychological Association, our Canadian Nursing, it's not required to get actual credits from an association in the same way as it is in the States.
Okay.
So it is required for physicians. So we have credits for specialist physicians and family medicine physicians. And then everyone gets a certificate that they've done the training and how many hours it was, but it's not like we don't get it through each organization, but you could do that. So ECHOs do give continuing education credits in the States. We just don't have the same number of organizations that actually administer them in Canada, but we have done them in medicine because it is required through there. But I have my certificate for psychology. When I do my reporting in my province, which is like your state, I can say I did 9 hours of the ECHO through this program. And this is what it covered. And it would still qualify as interprofessional training, ethics. There's always a session on ethics. So you can do that.
That's great. Thank you.
No problem. Okay, so I'll just show you. This is just it's just a visual example. And this is just one ECHO. So it depends. Each ECHO, like I said, we might have 100 people participating. We might have, and again, ECHOs typically might have been smaller before, but we thought during COVID, we can't afford to exclude people. Let's find ways to make it feel more intimate, but let's lots of people join, because if they need this information right now, give it to them. There's no time, right? And you can see the types of people participating were a range of different disciplines. Every time we do it, the distribution looks a little different, but we're really trying to work with people across areas, because the stuff we're teaching is like common language stuff that everyone can relate to, as opposed to something very specialized only for one discipline or profession. And then this is just one visual as an example. So we ask people about sort of how comfortable they feel in these different areas related to the healthcare that they're providing. So communicating with healthcare providers, managing the mental health issues of people with developmental disabilities, attending to their own self-care during the pandemic, working as part of an interprofessional team, and then that's the average score. And basically what you see is everyone's ratings have gone up. And in this study, we actually followed people 10 weeks after the course was over to see how they were reporting, how they were doing, and whatever it was that they reported that shifted was maintained. Satisfaction is really high. The kinds of things people seem to really like about the echo, I think this maybe is the next slide. No, this is telling you how we actually structure it. But the people seem to really like the interprofessional nature of it, the bringing together the different sectors. They really appreciate, and we could talk for an hour about this, instead of having like a session about patients or families where you have a bunch of people give the patient experience or the family experience, they're an integral part of our hub team. So they're there every week. They're involved in the teaching, they can be involved in the facilitating, they give their comments or their recommendations when we ask for recommendations. So it's integrated into what we do, and they see how, and we have had to learn as a hub how to work respectfully with them. And we've had to figure out how to support when they hear someone presenting a case in what seems like a fairly insensitive way of talking about someone with a disability, for example. We have to figure out how, as a team, how to have their backs and support them and kind of work through that, you know? So we're modeling something that teaches a lot, even if we don't say it, to everybody who's participating. So if I have time, I'm going to just show you quickly how we structure our echo. Does that work? And then I think I have maybe 3 slides after that. So if we were having a 90-minute session, and that's how long our sessions are, we thought if we made them an hour, it's too short. If we made it 2 hours, we thought not enough people would register. So we sort of start with announcements and introductions. They take 10 minutes, and it seems kind of like, wow, can we just skip the introductions and get to the meat of the matter? But part of the echo is really about building this community. Like, it's fun. You know, if it's a holiday, you wear a funny hat. Like, you talk about your favorite food. You just do things that are like really embedded in what's actually going on that's upsetting or important, but also what's fun. And so it's important to see who everybody is and know where they're from, including reintroducing the people in the hub team and their expertise. We always do some kind of mindfulness practice. It's very brief. It's often led sometimes by the person with a disability or by the family advisor in the course, but it might be led by another one of the clinicians in the hub. And we've actually started integrating in the new echo that we're doing physical activity. So we take a break after the teaching before we get into the case, where we have music and we get up and we do exercise. I can send you the links to the videos we've made, because you can do them sitting down if you're not able to stand up, or standing. So you see the video in both ways. And we get everyone to do it in the echo, but we say you're also welcome to use these with the people that you're working with. We talk a bit about what's going on this week with COVID. So, you know, if I was teaching this week, I might talk about the approval of the vaccine for kids under 6 in the US, if I lived in the US, right? Or I might talk about, you know, a new study that came out on people with developmental disabilities and COVID that people weren't aware of. So any kind of policy issue or research that's relevant, we give a little update on that, and we share links to keep people kind of in the know. And then we have teaching. The teaching lasts about half an hour, sometimes 25 minutes. We really stick to our time. And it's applied. It's like, here's the resource, here's the tool. So it's like light on the content and heavy on the, give me the tool that helps me do it, right? Whereas often when we teach, we're very heavy on the content and then light on the application. So we're kind of flipping it over a little bit. It's short and sweet. It's the most important stuff. If you want to read more about this, you can look at this resource, right? But we're making sure we make it very practical. And we always have a patient and a family perspective, unless they're actually teaching it with the other clinicians. We always make sure we give that lens as part of what we teach. And then we get into the case. And so we always want to try to keep at least 40 or 45 minutes for the case and the wrap up. And if anyone's been in an echo, it's a very specific structure. So we have a form that's online through REDCap, and people fill out information on sort of the demographics of the individual and clinically what their issues are. But the framework for how they go through the things is the same way as we've taught the framework in our first session. It's always how we conceptualize cases. So it's very sort of biopsychosocial, looking at the person's strengths and resources, considering, you know, trauma, risks, things that have happened from their lived experience. It's not just here's all their diagnoses and here's all their risks, right? So it's presented, and then the facilitator kind of echoes back. This is what I heard. This is how I'm understanding the case. Do I have it right? Yes, great. Any questions to clarify? First the spoke, so first not the clinician expert hub team, but everyone else, and then the hub. And so clarifying questions allow us to get a bit more detail on the case. So someone raises their hand and say, well, have you thought about this? Like when you said that they're not taking any medications at all, is someone monitoring them? And then they give their answer. So it's like question, answer, question, answer. After we do that for a while, we switch And we say, okay, now we're going to get into recommendations. And we make sure people hold their I know you have ideas, but please hold off on giving us recommendations until it's time for the recommendations. And then it's recommendation time. And we always start again with people in the broader community making recommendations. And generally, we don't step in and say, that's a terrible recommendation. We may end up reframing it a little bit, but we're really trying to let people be comfortable saying, here's just an idea I have. It might not work, but, and people give their input. And then we switch to the hub and they give their recommendations. And again, we try to give the recommendations in that same way we're teaching people to formulate their cases. And then the person who's facilitating the session says, okay, thank you, this is great. I'm just going to sort of review the kinds of recommendations people spoke about. What do you think of that? And they give that live review. And then the person says, yeah, that sounds amazing. Never thought about that before. Thank you so much. And then our job as the hub, which isn't written down here, is we then write up a summary of the case. So they get a summary of the case and all the recommendations with resources and links. I guess that's their incentive, Janet, right? Is if you do go through the experience of presenting a case, you do get some really valuable information back. And sometimes people have used it almost as an advocacy piece in their agency, right? They say like, you know, I gave this very, you know, de-identified presentation of this individual. I had permission to do so. This is what this group of people thought of. And here's things we hadn't thought of doing before. Maybe we should think about doing them. So that's the program in a nutshell. And then we sort of wrap up. So I think ECHO can be a very helpful way for us to do our education in this sector. I think this philosophy of all teach, all learn just fits so beautifully because it really recognizes the strengths of different people. Because if you don't call out this hierarchy of who everyone thinks is an expert versus who isn't, you have a problem, right? And I think the only way people are going to learn to work together is if they actually play together when they do the teaching and when they do the learning. We have seen improvements. We actually see that we are using this model also. So the one I presented was mostly directing it toward healthcare and social service providers, but we're also using this model. We've been exploring how to use it with families as the sort of learning group or with self-advocates as the learning group. So same principles, but sort of you can give it to whoever your community of learning is can still manage or learn from these principles. I think that you can really make it nuanced or you can go very broad. So the example I gave was very broad, but we did another ECHO, not last summer, but 2 summers ago. And it was just for managers working in disability services. So they were just sort of recovering. There was so much stress that had happened in the sector. And they just kind of needed like something that was for them to figure out how they deal with, you know, staff not showing up to work, families being so upset that they couldn't see their loved ones, managers feeling burnt out themselves. So it was a very nuanced ECHO on sort of leadership and mental health support for managers in that sector. And they were the only people who attended. So I think you can sort of pick a very select audience. The ECHO that Janet was mentioning around autism, they might only target it toward pediatricians, for example, right? Or they'll have one that's only toward behavior therapists working with young kids with autism. So you can have a very specialized ECHO, or you can have a broad audience, and I think both can work. So now I'm going to stop sharing my screen. There's a slide at the end, and I included it in the email. So we have a paper on our COVID ECHO, and then we have a link to our ECHO program that you can see.